So nuclear perfusion test is only available in select centers. Even in Sedang, we do not have it. So basically, they require introduction of radionuclide substances, basically thallium-201 or technetium-99, as it moves through the venous system. So they look at the ejection fraction, wall motion abnormalities, blood distribution, and so on. So you have the same data you get from stress echoes. Some people say it's more sensitive and specific. These are your conventional projections, these three. You have to do at rest and stress, and this is how a normal one looks like. And the sensitivity is pretty high. In good hands, it can be 90-95%. But the problem with this is it's not available in many centers, and it involves radioactivity. Now, cardiac MRI is the in thing, and in the last 15 years, it has grown so much. Before this, the indications are only 5. Now you can look at infarct size, inducible ischemia, other function, and you can use it in the entire spectrum of your coronary artery patient. It can be the acute patient, it can be chronic cerebral angina, evaluate the LV viability, LV thrombus, and apart from that, we can also use it for even congenital heart disease, looking at anomalies of the cardiac system and things like that. And there's no radiation. So it's very, very good. And when it comes to evaluating viability and so on, we give gadolinium. So the gist of it is, if you see these white areas, bright is dead. So this is dead muscle, the dark ones are still alive. So it actually correlates quite well with histological cross sections. If you can see here, you can see transmural infarct, that means it's completely infarcted. You can see the white gadolinium advancement here. You can see subendocrine infarct. So it's very, very precise. It is done in the right place. But the problem is the cost of the equipment and the specialty, the skills need to interpret it, you have to acquire. And cardiac CT is now becoming much, much more commoner. In fact, it's just any CT scan now, especially those with 64 slides minimum, 1 to 8, you have 2, 5, 6, even 5, 1, 2, but you can actually have cardiac CT. But the thing is, the protocol to do it is very important, and the best thing about this is it is considered non-invasive. Okay, there are issues, patient can be allergic to the contrast and so on. So CT angiography is gaining more and more widespread usage, but still it is not to be used as a screening tool for CAD in the asymptomatic individual. But now we are having more and more data for the symptomatic individual. But maybe in the future, things might change. I'm not sure. Another interesting thing is coronary calcium. So before we actually do the, before we proceed with the scan, sorry. Okay, so this is how the cardiac CT pictures look like. These are more for the patients. Okay, these are the virtual projection. Okay, we look at the more mundane ones, but you can actually look at your left coronary artery, right coronary artery. Other anomalies are very well seen. And the other thing is, this is how we look at. So this is the right coronary artery coming on the left, sorry, at the right, and the left coronary artery, the left main is coming out, and you can see dots of white things here. Those are calcium, and these are very good modality for bypass grafts. So when you have patients who undergone CABG, to repeat the angiogram or graft study in them is risky, it's more difficult because you have to look at native and also bypass grafts. So coronary CTs are very good because the bypass conduits are actually quite large, quite big, easily seen on CT, and you know which one is obstructed and so on. So there are challenges. You need to slow down the heart rate, move the coronary arteries. The smaller coronary arteries can be an issue. But this is an anatomical test, but the future is changing. People are now able to do functional. I will mention this later with coronary CT. The other interesting thing is calcium score. If you have a calcium score which exceeds 400, usually we'll stop there. Calcium score is a very fast scanning. You don't have to actually do coronary arteries. calcium, we do calcium score first, because if the calcium is very high, more than 400, you might not be able to see the lumen of the coronary arteries. We will actually advise you to do an invasive coronary angiogram. So this is how a calcium score will look like. We can color code them, circumflex, and so on. So that is the CTE. Okay, but whatever we find on the CT, the negative predictive value is very good. If it's negative, it's good. But if you find a 70% lesion on CT, when you do a coronary angiogram, it could be just 50%. Usually CT tends to overestimate the lesions. Of course, coronary angiogram is the more invasive test. I will not go into details of this. I'll show you an angio later. So this is how in the cartoon, the RCA and the left-sided LAD and circumflex coronary arteries look like, and it carries the risk. So it is an invasive procedure. It is still 99.9% safe. So 1 in 1,000 patients, when we do the angiogram, they can actually end up having serious complications. So it's still safe. If you do angioplasty, the risk is higher. It's 99% safe. But these are in the straightforward lesions. Those with poor ejection fraction, triple vessel, left main disease, obviously the risk can be actually higher. So what are the new modalities? I'll just touch on this briefly. One of it is what we call FFR, fractional flow reserve. And this is a tiny wire. It's invasive. That means we introduce this when we do the angiogram. And it's quite costly, but now it's becoming more widespread. It's about almost 1,000 USD per wire. It's the smallest Doppler probe. You insert into the coronary artery and you look for the flow and you give adenosine. There are newer versions of FFR now coming out, RFR, IFR, and so on, flow reserves, where you do not have to give adenosine. Okay, and this really helps your stenting, because eyeballing, you look at the 70% lesion. When you look at the flow, it is actually preserved. So basically, indirectly, you are measuring coronary blood flow, CB, or coronary blood reserve. So if your FFR is more than 0.8, it's an indices, you do not have to do anything, just medical treatment. Anything less than that, then you have to consider revascularization. It can be either bypass or stenting. So this is what I mentioned. Now, even with CT, you can actually get just by via non-invasive methods and mathematical calculations, they can actually know the flow and whether the lesion is significant. It's still catching on because it's pretty expensive. So maybe this is the future where you can actually have a 3D rendering of your coronary artery, and you can even simulate, like on the right here, if you were to stent that area, what will happen to your indices. And if it improves, then you can go ahead and stent. So this is maybe future where you can actually have, these are still at the moment experimental, where you can have coronary flow maps of your heart, so you know what is happening, because PCI angiograms and everything are only looking at your epicardial coronary arteries. They are not looking at the endpoint of the capillaries, the intramuscular, intramyocardial septals, and so on. So in summary, this is actually from the guidelines of 2018. To make a diagnosis of CAD, history, physical examination is important. ECG is preferable, definitely. Echo is not a routine investigation, but if you ask me, it is indicated to look at the LV function. Chest X-ray is not routine investigation, but it is helpful at least to get one, chest X-ray done. And then the second recommendation is those you suspect have coronary disease, always have an idea of the pretest probability. So if it's less than 15% low, you might not need to do anything. If it's intermediate, then they require non-invasive evaluation, 15 to 85%. If it's very high, you can jump straight to the more invasive, angiography, coronary angiography, and so on. So these are patients with suspected CAD. Those who have events, you're already going in for high pretest probability. So most of the time, we will just jump into the more invasive tests. And you have to know the sensitivity, specificity of the different tests. And after you have done all those, then you have to decide whether you want to go the next step. So whether you want to do a functional stress imaging test in those with intermediate pretest probability. Most of the time, I think the general physician clinic, you do not have stress echoes, so you need to refer to a cardiac center and things like that. So at the moment, that can be a bottleneck, especially those who have uninterpretable ECGs, other contraindications to stress testing. And coronary CT is another way where you can look at the coronary calcium. It's useful for severe risk assessment, but asymptomatic patients with coronary calcium, we still tend to do functional tests first, so it's still debatable. And then if the high test probability, you actually go to the next step. So basically, you want to re-stratify patients into low risk, where the annual mortality is less than 1%, intermediate risk, where the annual mortality is 1 to 3%, or those with high risk, annual mortality more than 3%. But if you look here, nowhere uh, it is mentioned 0%. So even in low risk individuals, even with normal coronary angiograms, I've seen them having myocardial infarction and so on. Sometimes there are other reasons why they have it. They have an unstable plaque, they're smokers, and so on. So basically, take home message, the type of test depends on clinical indications and scenarios of the patient. You have to know the pretest probability, especially if the diabetic, hypertensive, dyslipidemic, smoker, you already know they are already intermediate to high. So no one test fits all patients. Okay, so you have to tailor make the test to the patients. So generally, functional tests are better at predicting outcomes, and the typical tests are suitable for high probability pretest probability patients and those who already have an event and are candidates for intervention. But there have been times when we do a coronary angiogram, we find a 50% lesion, and actually we go back and do a stress test to see whether there's a functional significance. Of course, now we can put in an FFR wire and estimate the blood flow, but it comes at a cost and so on. So usually a combination of both functional and anatomical are required to make a proper diagnosis and treatment, and it is temporal in time. That means a patient who has a negative stress test this year can have a positive stress test next year. So if you have high risk patients, this is a continuous spectrum way to evaluate yearly. Maybe if diabetic, hypertensive, yearly stress test. If the younger patients, maybe 2 yearly, and so on. So I've finished my lecture, and I hope that it has benefited. But I will go on to just one case where I'll show risk stratification quickly. A 40-year-old Indian male who's an ex-smoker. He's a Grab food driver. He has diabetes for the past 10 years. A lot of Malaysians are presenting with diabetes much younger, even 30 years and so on. He also has hypertension for the past 10 years. I didn't put here, but he also has dyslipidemia. He presented with chest pain to a medical clinic in tertiary hospital, left-sided, sounded typical on and off, but NYHA class 1, he's never been admitted for acute coronary syndrome. And unfortunately, in Malaysia, the way it works is, they go to the GP clinic, they wait 3 months or 6 months to see a physician in a general hospital. By the time they refer to Sedang, for example, another 6 months is already, the 1 year. We get a test done, it'll be another year. So hopefully the system can change. But looking at this guy, the pretest probability of 48-year-old diabetic is minimum 70 and above. So it's already intermediate. I used my smartphone to calculate its intermediate in the Diamond Forrester plot. And this is the ECG. He has a RBB, right bundle branch block. Well, nothing exciting. Well, you can do a stress test with this. So, or we can do, proceed on. So we did an echo. EF was depressed, 46%. And left ventricle was normal size, and mild MR, mild TR. Okay. And what would you do next? Okay. With the exercise test A, the vitamin stress test B, cardiac CT, C, D, coronary angiogram. There's no right or wrong answer. And I think we can poll now, please. I will not know the answer because I'm pre-recording this, but there's no right or wrong answer here, except for coronary angiogram. I will not go for that. So we did the exercise stress test, but patient was not able to complete stage 2, stopped due to shortness of breath. So it was an inconclusive stress test. So what to do next? So whether we do a dobutamine stress test, whether you do a cardiac CT or coronary angiogram, we can poll also on this. But it's interesting to know what to do, because at the end of the day is what the patient wanted. Okay, we could have done a stress echo, but patient was more keen for anatomical test, so we went to do a cardiac CT. So on CT scan, we found that he has triple vessel disease. Okay, but sometimes CT scan, as I mentioned, can overestimate the disease. So we need to do a coronary angiogram and see whether he truly has triple vessel disease. So usually the radiologist will report this. They have their nomenclature, and or the cardiologist report this at red 3. So the one we're worried about is usually the left main, where there doesn't seem to be, they say moderate stenosis about 50%, LAD seems to be significant. So when we did the look at the CT, you can see calcification in the LAD, and then this is the ostium of the circ. And so what we did next was we went on to do the coronary angiogram. Patient was agreeable. So even before going to the cardiac CT, we already asked the patient, if you have 3 blockages, are you agreeable for the next step? If he has said no, we would not waste our time. Even before that, we actually asked him, so where are we going with this? So that's very important to have that discussion before you do all these expensive tests. At the end, the patient says, oh, doctor, I don't want anything to be done. So here was 3 vessel disease. There's the long proximal to mid LAD diffuse, circumflex. So the first choice usually is CABG. So in this patient, when we discussed, he was more keen for intervention and not CABG. One of the things in Malaysia is our waiting times for CBG is very long. In our center, it's more than a year. If you're in private, obviously they will do it tomorrow, but that's the problem. So most of the time end up with PCI. So we did the PCI to the, this is the RCA. You can see it's just horrible. It's just a string of strings. So this is a non-dominant small RCA. So what this tells us is usually the circumflex can be quite big. So this is your LAD, as you can see. It's actually has a long prox to mid stenosis. It's tortuous. Even the mid LAD, there's a tight stenosis. And on the right-hand side, you have proximal circ disease. So sometimes we cannot do everything at one go. What we do is we stage. So this is the final result with, I believe, we use 2 long drug-eluting stents. Now all stents are drug-eluting. This is via femoral approach. And we stage the circumflex to another setting. And what's interesting is with the circumflex, we escape without putting a stent. This is your pre, this is post. We just use what we call drug-eluting balloon. So there are pros and cons. I want to go into. So it doesn't end here. If it doesn't take its medication and so on, you'll be actually seeing each other in the next 6 months to 1 year. So this is lifelong treatment. There's no cure for this, and you have to evaluate him after 1 year again with whatever stress test or the vitamin stress echo and so on to see how is he doing functionally. Yeah. So thank you, and hopefully by end of next year